The All Eyes Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Welcome back to part 2 of my interview with Dr. Daniel Montenegro. In this episode, we continue our discussion on the treatment of viral eye disease. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Now, let's talk. It is very confusing, so for everyone to follow. So we start off with the epithelium. We started off with the infection of the epithelium. Now we're going to still stay with the epithelium, but it's not infectious anymore. It's an immune neurotrophic keratitis. Talk about that. How do we diagnose it, and how is that treated?
So what is neurotrophic keratitis? So neurotrophic keratitis is a patient whose eye does not feel what you see on the exam. So a patient has an ulcer in their cornea, and they come in with loss of vision, decreased vision, and they have a central ulcer in their cornea. And an ulcer, by definition, means that the stroma, the middle layer of that cornea, the thickest layer of the cornea, is starting to get thin. And they don't feel anything. They don't have any pain. That's called neurotrophic keratitis. Neurotrophic keratitis is more common in herpes zoster infections. Patients that had a rash on their face, patients had a rash on their forehead or their nose or their cheek, and they have vesicles around the eye, and they might also have a dendrite under cornea. That's herpes zoster. That's different than herpes simplex keratitis. They have herpes zoster and possibly herpes zoster ophthalmicus. Those are the patients that are at higher risk of having neurotrophic keratitis, where they don't feel pain in their eye. And that's a bad thing. That's a bad thing, because if they don't feel pain, then the eye doesn't heal. You need that pain comes from the nerves, and you need those corneal nerves for proper healing.
So these patients that have these non-healing ulcers, what are we doing with them now? Are we putting them on oxivite, or do you have a specific strategy for them?
So it all depends on how bad their neurotrophic disease is. There's the Mackey classification for neurotrophic keratitis. The Mackey classification is very useful, and I recommend all optometrists and all ophthalmologists to be very familiar with the Mackey classification for neurotrophic keratitis. So Mackey classification, stage 1 neurotrophic keratitis, you have an epitheliopathy. A patient can have a dendrite, which is by definition an epitheliopathy. a dendrite or a non-healing epithelial defect. That's Mackey stage 1. Mackey stage 2 is more severe. Now you have a large epithelial defect. It's no longer a dendrite, it's now a large epithelial defect with rolled edges. Whenever you see rolled edges around an epithelial defect, that's very characteristic for a neurotrophic epithelial defect. That's stage 2. In stage 2, the stroma is not ulcerated. There's no corneal ulceration, no stromal ulceration. In the Mackey stage 3 phase, you now have an epithelial defect and you have stromal thinning or ulceration. So in Mackey stage 1, where it's just epithelial disease, you can treat these patients with aggressive preservative-free artificial tear lubrication every 1 to 2 hours, ointments at bedtime. You can put punctal plugs. Punctal plugs are little temporary or permanent plugs on the puncta that help tears stay longer over the eye. Or you can start serum tears. You can the patient can have blood drawn from their vein, and they can have artificial tears or serum tears made from their blood. And that has growth factors that promote healing. That can be used in early neurotrophic keratitis. When you're in later stages, stage 2 or stage 3, now you start getting into other more aggressive treatments like amniotic membranes. Amniotic membranes can be put on the surface of the eye. An example of that is a Procara amniotic membrane ring. Or you can also start these patients on Oxervate, which is human nerve growth factor that was FDA approved and developed by Pompe Pharmaceuticals. Oxervate cenegermin is very effective in the treatment of neurotrophic keratitis.
Let's move to the stroma, and first let's talk about the infectious disease of the stroma, necrotizing stromal keratitis. That's the one that we're all scared to death of. Talk to us about that, and how do we pick that up early? And God, that's luckily it's not that common. But I mean, maybe it might be common for somebody like you because everybody refers to you, but for the average optometrist out there, it's not that common.
So necrotizing keratitis, it looks like a bacterial ulcer. You essentially have a thinning of that stroma, and you're starting to have degradation of the stroma. So you have necrotizing keratitis and you have non-necrotizing keratitis. Both necrotizing and non-necrotizing affect the middle layer of the cornea, the stroma. And in necrotizing keratitis, it's believed to have live virus. So this is live herpes virus that's causing degradation of the corneal collagen in the stroma and causing a lot of intense inflammation. So because it's an immune-mediated mechanism, that's treated with topical steroids, Carrie. So when it's necrotizing keratitis and the cornea is getting thin, we know it's not bacteria, it's from herpes virus. That's caused by the virus, by the immune system, the immune inflammation, this immune-mediated damage. So we treat that with steroids. However, we typically treat with steroids and antiviral, because if we just treat with steroids alone, what's going to happen? We have a higher likelihood of reactivating the virus if we're only treating with steroids. That's why we often treat them with steroids and antivirals, so we cover both things.
And are we using the standard dose of the antivirals for herpes simplex, or are we giving the Zoster dose?
So it depends. You can have necrotizing keratitis in the setting of herpes simplex or the setting of herpes zoster. Now, if you're dealing with herpes zoster, a patient had that classic vesicular rash on their face, you're going to give them the herpes zoster dose, which is always double of what the herpes simplex dose is. It's always double the dose. If you have a patient with herpes simplex keratitis and they start to develop ulceration of their stroma, necrotizing keratitis, you're having more severe disease, you might bump up the dose you might double the dose or bump it up. treat a little bit more aggressively, and nobody's gonna blame you for that.
I got a question for you. Why is in Zoster, why is the dose double of what it is in Simplex?
The dose is double with herpes zoster because the virus itself is different. And we're going with this dose for herpes simplex based on the HEADS study. We've always known that herpes zoster, it's more hurt in the setting of herpes zoster ophthalmicus, there's more tissues affected. There's more tissues affected. It's a more aggressive virus and it requires more dosage.
Because it's more of a systemic disease rather than a localized disease.
It's more systemic. It can affect more tissues.
Interesting. Thank you for that. So now let's talk about, we're still in the stroma, but now something that's pretty common, a stromal interstitial stromal keratitis, which is non-infectious, which we see a lot, and a lot of times doctors are confused and the patient winds up going to a lot of different doctors, and when in doubt, it turns out many times to be herpes. If you could talk about that.
Yeah, so you're going off if you see a patient that's brand new to you and they have interstitial infiltrates. So it's an interstitial keratitis. The infiltrates are in the middle layer of the cornea. There's a couple of things that could cause that. You have your bacterial infections that can cause similar appearance in the periphery. But if you have infiltrates in the center of the cornea, this can be from adenovirus. You can have subepithelial infiltrates after an adenovirus infection. But in the setting of herpes simplex or herpes zoster, interstitial keratitis is caused by inflammation, not so much live virus as in necrotizing. It's inflammation in the middle layer of the cornea, and you can treat these with topical steroids.
And is this treated with topical steroids and you cover it with antivirals?
So you can treat with your topical steroid alone. You can treat with your topical steroid alone, but then always be on the lookout for live virus activation. So if you only treat inflammation, you will sometimes have a reactivation of that live virus if you're only treating with steroids. So that's why most often we treat with both antiviral and steroids.
Now, typically, in Florida where you are you using Valtrex or using acyclovir, or is it really just based on insurance? If the patient is covered with both, will you be more likely to use Valtrex?
Both are covered by, both are available generic now, Carrie. So you can, I think for most patients, you should be able to prescribe valcyclovir or Valtrex, because Valtrex is now available as valcyclovir generic. So you should not be having any major issues as far as coverage, and it should be affordable.
And it's just easier because it's 3 times a day rather than 5 times a day.
Yes, the dosing is easier. Patients are more likely to be more compliant, and it's just as effective as acyclovir.
So let's move on to endothelial disease, disciform keratitis. Talk to us about that, and what does that look like?
So a disciform keratitis is a very unique kind of herpes keratitis. It's when the virus itself the virus has infected the endothelial cells in the inner layer of the cornea. So it's an endothelitis. And what you'll see is an inflammatory plaque in the endothelium. So you'll see localized corneal edema. We know that when endothelial cells are having a hard time or they're infected, what happens is that their water pumping capacity is reduced, and you'll have swelling and localized swelling of the cornea.
And this could be to an active infection, or it could be an immune response. Is that correct?
That's correct. It can be both. So we typically treat endothelitis or disciform keratitis with both steroids to decrease the immune reaction, and also antiviral to decrease any possible live viral activity that might be causing this.
And are we using, do you ever use Viroptic anymore, trifluoridine, or is that something that you just, if you're going to use topical, you're going to go to the
Zergan. Yeah, if I have to use
gel.
topical, I'll go with Zergan gel. Every time, no question. I think some of the more, some people still use trifluoridine, is what they're used to using, but in my own experience, I find that Zergan works well when needed.
What I think is interesting is acyclovir is actually topical in Europe, but not in the United States or outside the United States.
I didn't know that. We have trifluoridine and ganciclovir, which is Zergan. Yeah, ganciclovir, which, by the way, ganciclovir is also used to treat other atypical viral infections. If a patient has a cytomegalovirus disease in the cornea or inflammation, ganciclovir is what's used to treat that.
Now, I want to go back to primary herpes for just a second with children. What's the oral syrup dose that is typically used? Is that something that you would know offhand, or you would have to work with a pharmacist on something like that?
I would work with a pharmacist to do the conversion.
Or the pediatrician or something.
Yes.
And so let's talk about ganciclovir, how that's used and side effects, if you could talk about that. So we kind of went through all the different types of herpes infections, epithelial, stromal, endothelium. We went through how to treat each one of them. So I just want to kind of, even just to repeat, because it's very confusing. So Zergan is used 5 times a day. For how long and what kind of side effects, in your experience, for someone that does a lot of this, or you hardly ever see side effects?
Zergan is very well tolerated, and Zergan can be dosed at 4 to 6 times a day in the affected eye for about 10 to 14 days. And you'll use it more in the setting of epithelial disease if a patient has limited epithelial disease, such as a dendrite, or even a dendrite that's developing into a small geographic ulcer. So what you'll see in epithelial disease is a dendrite, but then if you have many different dendrites, those dendrites can coalesce. When a dendrite coalesces with others, it'll form a geographic defect, a geographic epithelial defect. In that setting, you can use an oral antiviral, or you can use Zergan.
Now,
so you can use either one.
Now,
they're both equally effective.
So recurrence, you've had herpes, unfortunately, a patient had it. Recurrence is pretty high. That somebody had it once, they're going to get it again.
Yes.
So now people are being put on prophylactic medication,
Correct.
whether it's Valtrex or acyclovir. Is that something you typically do? And if you do it, what is the prophylactic dose that you use?
So if a patient has epithelial disease, this is very important. Epithelial disease, even if you don't treat epithelial disease in an adult, most of the time epithelial disease is self-limiting. So if you did nothing, more likely than not, it's going to resolve. But we still treat to lower the duration, and you don't want anyone left untreated, honestly. So epithelial disease you will treat if it's herpes simplex with acyclovir or valcyclovir for about 10 to 14 days, plus or minus topical Zergan, plus or minus 10 to 14 days. Once you treat them, they get better. Their cornea clears. They don't need a prophylactic dose. They don't need to stay on the Zergan, the valcyclovir or the acyclovir long term for the rest of their life. If a patient has stromal disease or endothelial disease or trabeculitis, high intraocular pressure, but let's stick with stromal disease. You treat them for 10 to 14 days with the oral antiviral and possibly steroids. Once it resolves, they have a higher risk of about 10% of having a reactivation over time. So these are the patients that are more likely to reactivate, the patients with stromal disease. So we tell them they should be on a prophylactic dose of acyclovir or valcyclovir for at least 1 year. And the reason is that you want to prevent stromal disease, which has a more likelihood to cause vision loss. And what we're trying to prevent here is vision loss from herpes virus, which is the most common cause of infectious related corneal blindness in the world.
And what would if you're going to do a prophylactic dose, what would it be?
It would be acyclovir. In the setting of herpes simplex, in the setting of herpes simplex, it would be acyclovir 400 milligrams twice a day, or valcyclovir 500 milligrams once a day.
The All Eyes Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not
Right,
multifocal.
exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. From your experience, patients that have been on prophylactic dose, how have they done?
They do great. The medication is very well tolerated. It's metabolized by the kidney, acyclovir, so you do have to tell them to drink a lot of water. And if a patient has any stage of kidney disease, diabetics, hypertensive patients, if they have any stage of kidney disease, they should definitely consult with their nephrologist or primary care doctor and let them know that they're starting this medication, because it can cause an increase in their labs and decrease in their overall kidney function, meaning it can worsen your kidney disease.
And the same thing with type 2 genital herpes. I've seen patients that have been on prophylactic doses for years. So
Yes.
as they're on it for years, that's something that they have to worry about or be concerned about, of having kidney or liver disease.
Yes, definitely. I mean, kidney disease more so with acyclovir. Valcyclovir affects kidney function less, but there is a renal adjusted dose for these medications, by the way. But that's something that their nephrologist or primary care doctor might help you determine.
And are there any other points from the head study? The head study shows that we could use that it was safe to use steroids, and that we could either use topical or oral medication. How about from heads 2? Is there anything from there that we've learned that maybe that you didn't talk about that the audience should know about?
From the heads 2 study, that one I don't recall right now, Carrie, at the top of my head.
Okay, yeah. So that was really that was prophylactic. I mean, you just kind of talked about that prophylactic is important. How about limbitis, the limbus being inflamed?
So a limbitis is a reaction of the limbus itself. You can have injection of the limbal stem cells, and it's just a localized inflammation of the limbus. You might see a little bit of pannus, corneal neovascularization in the setting of a limbitis.
Now let's talk about zoster or chickenpox. You talked a little bit about it. Why do people get zoster? They've gotten the vaccine. A lot of people have gotten at childhood, they got the vaccine. Now, me personally, I had chickenpox as a kid. I'm older than you are, so that was before the chickenpox vaccine. But a lot of people have gotten the vaccine, but still get shingles.
Yeah, I mean, the prevalence of shingles, which is infection of in the setting, we'll focus on herpes zoster, which is the herpes zoster, the trigeminal ganglion infection. We have 3 divisions of the trigeminal ganglion, 1, 2, and 3. So when herpes zoster is activated, this is an infection and a reactivation of this virus in our trigeminal ganglion, and it can cause a vesicular reaction in the 1st or 2nd division of the trigeminal nerve, which causes a characteristic unilateral rash on the left or right side of the face. It's always unilateral, and it'll respect the midline of the face. That's how you know that this is herpes zoster. Another condition on the differential, if let's say this vesicular rash does not respect the midline, now you might be looking at another bacterial infection like an erysipelas infection, because those will not respect that midline of the face. So herpes zoster is very prevalent. There's a very effective vaccination that will protect adults over the age of 50 from herpes zoster. And we're recommending everyone, especially patients that are immunocompromised over the age of 50, to go get their dose of the herpes zoster Shingrix vaccine, which has been shown to be very effective. It really reduces the incidence of herpes zoster in adults.
Something that's confusing is that children have gotten the Zoster vaccine. So why do they get the reactivation of and get shingles?
Our immune system wanes. Our immune system is reduced as we age. So our immunity goes down gradually as we all age. So that's why, even though we were vaccinated when we were children, now as adults, our immunity goes down and we can have a reactivation of this virus.
So is it a reactivation of the live virus that was put into us by the vaccine? Because these people never had chickenpox. So now they're getting shingles. So where'd they come from? That's my question. And I don't know if anybody knows the answer to that.
Yeah, well, what I do know is, I'm not sure about that either, but I do know that the vaccination is there, and we're seeing, Carrie, what's your estimate? I mean, I'll ask you a question. What percentage of Americans do you think are getting the vaccine for shingles?
I would say about 70.
70%?
Yeah, is it that high or no?
Getting the vaccination? It's actually less than 10%.
Oh, geez.
Yeah, less than 10% of Americans are getting the shingles vaccine.
Oh, okay.
That was shown in a very nice study published in Ophthalmology. And it showed that the vaccine was effective at reducing the incidence of herpes zoster ophthalmicus. This was published in Ophthalmology recently. And that amongst Medicare beneficiaries, less than 10% that were eligible for the vaccine were actually getting the second dose.
They obviously weren't taking a poll at Century Village. So about people that get shingles, they get the herpes zoster. About 50% it affects the trunk, and about 20% it affects the cranial nerves. And out of those 20% that affects the cranials, 50% will affect the trigeminal nerve. So talk to us. The patients come in and they have zoster, and now it's affecting their eyes. What do we need to look for? How serious is it? Is it usually less serious than simplex, or equal or more serious than herpes simplex infection?
Harry, it's more serious than herpes simplex infection. More serious. First of all, let's talk about the patient who's immunocompromised. So if a patient, you know from their history that they're immunocompromised either from cancer or HIV, AIDS, and they have herpes zoster ophthalmicus, you need to treat this more aggressively, because now you're treating it as herpes virus affecting the central nervous system. So you can't treat this patient that's immunocompromised with just an oral antiviral. This patient that has herpes virus disease and is immunocompromised needs to receive intravenous IV treatment for the herpes virus, because they're at higher risk of having more serious complications because of your weakened immune system. The disease is more serious even in immunocompetent people, because herpes zoster ophthalmicus has a higher incidence of having neurotrophic keratitis. And neurotrophic keratitis, if not treated, identified or treated correctly, can cause a lot of bad problems with their cornea and their vision. And then once the patient develops bad corneal disease from herpes zoster, for example, permanent scarring or an ulceration, and the patient has lost a lot of vision, these are the patients that are not good candidates for corneal transplantation, meaning that with a corneal transplant that's clear, they they don't do as well. They have a lot of complications after any surgery because their eye is very neurotrophic. Their eye does not feel pain. The corneal nerves are just not good. They're not effective. They're not working as hard. You need corneal nerves for a healthy ocular surface. And that's what's missing in patients with bad herpes zoster ophthalmicus. And the neurotrophic keratitis does a lot of bad things to the corneal nerves.
And as you, as a corneal specialist, now what you're in that position, how do you approach that?
So I can tell you, I can go over a case I had.
Sure.
A patient that I treated who had Caucasian male in his 60s with a history of diabetes that came in with a herpes zoster ophthalmicus. He had a very, high grade vesicular rash on his face, and he started off with dendrites in his cornea. I treated him with the treatment dose of valcyclovir, Valtrex, for about 2 weeks. I followed the dendrite, but that dendrite, even with the antiviral, progressed to a geographic ulcer. And he had a Mackey stage 3 classification with ulceration of his stroma. What I did in this patient is that I put a Procara amniotic membrane. I'm not sure if you're familiar with the Procara amniotic membrane.
Sure.
It's a PMMA ring that gets inserted into fornix, and it has amniotic membrane. And this was done to reduce inflammation and promote healing. When I saw him the next time, guess what happened? Even with the Procara ring, once I removed it, his cornea perforated, Carrie.
Oh my goodness.
This patient had a flat anterior chamber with a corneal perforation, and he's sitting right in front of me. All of this because of bad herpes zoster.
Wow.
And he was treated the right way. So in this emergency setting, what we did was that we put glue on the patient's cornea, cyanoacrylic glue, and a bandaged contact lens. So once you glue a cornea to cover a perforation, you need to put a bandaged contact lens over it so that the contact lens protects the glue from the lid and it doesn't slough it off or remove it. We did this and treated him with prophylactic antibiotic to prevent endophthalmitis or an infection. While we were doing this, I ordered Oxervate for this patient. Oxervate is the recently FDA approved medication for neurotrophic keratitis. So we ordered Oxervate, it was approved, and he started using the Oxervate even when he had that bandaged contact lens on with the glue. He did the full Oxervate course for about 8 weeks. And after removal of that contact lens, his corneal ulcer resolved. He was left with a scar in his cornea. But that perforation went away and the scarring got better with the corneal glue and the Oxervate. So we treated his neurotrophic disease. And he's actually doing well. He developed a cataract, and we were able to do the cataract surgery on him through a clear cornea incision. And right now he's seeing about 20/60 uncorrected, which is very amazing.
Wow, that is a great case. And that's a scary case.
It is a very scary case, yes. This is what you don't want to see. So in any patient with herpes zoster, what you want to do is you can bring some dental floss from your home. You can have a small strip of dental floss, and you can just, without anesthetic, without proparacaine or tetracaine, if they've had herpes zoster, you want to touch your cornea with a clean dental floss in all 4 quadrants and measure corneal sensation and ask them if they feel it. If they don't feel the dental floss or a cotton tip applicator, then you know that that patient is neurotrophic and the cornea has less corneal nerves.
And
so you always test for corneal sensation in these patients.
So at the beginning stage where you test them and they don't have any sensation, but they're not having any issues yet, what do you do then?
You can do aggressive lubrication, preservative-free artificial tears. As you know, if you're going to treat somebody with artificial tears more than 4 times a day, those should be without preservatives, because the preservatives in artificial tears can cause toxicity if they're used very often. So preservative-free artificial tears, punctal plugs is an option. Serum tears is an option. You can order serum tears through Vital Tears. That's one of the many companies that's out there. Vital Tears works with Eversight. and they'll send a phlebotomist to the patient's house, draw the blood, and then they'll send the serum tears to their house. They'll do all the work from the comfort of your own home. So vital tears, artificial tears, ointments can be used at that early stage.
Even though Oxivite is supposed to be used at a later stage, would you use it at an early stage?
You can use Oxervate at any stage of neurotrophic disease. Oxervate, however, requires a lot of work with with the patient's insurance company, because it is very expensive. It costs about, I believe it's about $70,000 per month.
Well,
So that's something that a lot of patients can't afford. So Dompe works really closely with the patient's insurance to make sure that they can get the medication.
and how about ZEDS, the zoster eye disease study that's ongoing, using Valtrex prophylactically?
The ZEDS study is currently a phase 4 clinical trial that's ongoing, and it's looking at the effectiveness of valcyclovir, Valtrex, as a prophylaxis to reduce the recurrence of stromal keratitis and the setting of herpes zoster. We're still waiting for those results.
Now, something that's very important is that these zoster patients have to be treated within the first 48 hours. But some people get like a prodrome, they get a burning before they start getting the rash. If you could speak a little bit about that, to the patients out there that may be listening, that if they're starting to get that weird type of skin burning.
Yeah, it's a neuralgia, and that's the neuralgia, that dermatome feeling. Remember, the virus is affecting the trigeminal nerve in the first or second division. Very importantly, if you see the vesicles also affecting the nose, that's called the Hutchinson sign, and that increases the risk of ocular involvement. But yes, that sensation, that neuralgia, is something that can happen before the infection is developed in the face. And also the neuralgia can still persist afterwards. After you've been treating them with antivirals, they can still have that persistent neuralgia, which is like a headache. And that's one of the bad consequences or sequela of a herpes zoster infection.
I know you have to go because you have surgeries. I want to ask you this one last question. If you could just go over the dosage again for zoster.
So for herpes zoster, first line treatment is Valtrex 1 gram 3 times a day. 1 gram 3 times a day of valcyclovir for 10 to 14 days. And once you finish those 14 days, you don't need to continue treatment beyond that with valcyclovir unless they develop stromal disease. So if no stromal disease is present, treat for 14 days and that's it. Acyclovir would be 800 milligrams 5 times a day for 14 days. And if you're treating for stromal disease, for prophylaxis, it would be 800 milligrams twice a day.
Now, if they have epithelial disease and they're already being treated by their primary, and they come in and they have epithelial disease,
you keep on treating for those 10 to 14 days for epithelial disease, and then you can stop.
Would you use a steroid antibiotic on top of that?
No, don't use a steroid in the setting of a new epithelial defect. Stick with an antibiotic, moxifloxacin or ofloxacin, to give yourself some extra coverage for the epithelial defect. But don't treat with a steroid yet, unless the epithelial defect closes and you're developing some haze in the cornea. If you're starting to develop some haze, you can often see a ghost dendrite underneath that dendrite that resolved, a ghost dendrite, and you want to and it's in the central visual axis, then you might want to add a little bit of a steroid to reduce some of that stromal opacity. But, definitely wait a little bit after those 14 days to start treating with the steroid.
Well, I appreciate that. I want to thank Dr. Montenegro for joining me today. If people want to find out more about you and get in touch with you, how could they do that?
Yeah, of course. My email is a very good way to reach me. My email is D as in Daniel, that's my first name, Montenegro, my last name, if you spell it out, D Montenegro at myeyecenters.com. D Montenegro at myeyecenters.com.
And is there anything that I left out that you want to tell the audience before we let you go?
All of those out there who are primary care providers, optometrists, ophthalmologists, primary care doctors, ask all your patients 50 and older about vaccination against herpes zoster. And if those patients have not been vaccinated, tell them that they definitely should. It'll, make a big difference for them and also for us in our clinics.
I want to thank Dr. Daniel Montenegro for joining me today. You're a wealth of information. Thank you for sharing all that information with us. This is Dr. Kerry Gelb for Open Your Eyes. Thank you for joining us.
Gary.
The All Eyes Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.